for the nice introduction from the Doyens who have established the medicine in this part of the city as well as in the state. And I thank the opportunity given to me by Dr. Kumaravel and the organizing team of Receptor 2026. So as rightly pointed out, the talk is going to be a little bit boring only, because after that lunch session, thinking about assay, interpretation and the lab, going to the lab is definitely going to be boring, but I'll try to make it as short and as interesting as possible. So whenever a person comes to us with infertility, with menstrual disorders, erectile dysfunction, fatigue, or anyone who is getting any MRI or anything done for found out to have incident trauma, definitely pituitary hormone panel will be the part of the investigation. And so the diagnosis, it depends critically on the accurate hormone assay interpretation. So that's the most important thing. Many times in our busy practice, what we do is we just go through the hormone in a very rapid manner and we come to a diagnosis, instead of going into the nitty-gritties of what is behind that value. And that's what we are going to discuss. So if we misinterpret, what is going to happen? One is we are going to make a wrong diagnosis. That is, we label the patient as normal sometimes, who may be harboring some problem, or we may be labeling the patient as having a disease who is not harboring that problem. And second is, we are going to unnecessarily end up with investigations, MRI. Many times we are finding this with the elevated prolactin levels, patients undergoing MRI, then they will come, and then when we take the history, we will find out that there will be a tablet which is causing high prolactin, and then we will ask the patient to stop the tablet and the prolactin will become normal in the next 2 weeks. This is almost a day-to-day scenario in our practice. So instead of going to the hormone, interpreting it and going for the MRI, if we sit for another 2 minutes and ask the detailed drug history, we would have at least eliminated half of the MRI prescriptions from our clinical practice. Then inappropriate therapy, again, if you talk about prolactin, I'll be again and again going through prolactin. Probably I think that there is the most abused hormone in any clinical practice, more than thyroid function, I would say. So dopamine agonist, using of steroids in patients, we think that ACTH is less, and hormone replacement, everything is started because of we have not interpreted the assay properly. So treat the patient and not the paper. So before going into the real problems, what are the assays? This is just a basic thing. We have got two important kind of assays in our clinical practice. One is a competitive assay, another one is a sandwich assay. Competitive assay is mainly used for molecules like cortisol, which is a smaller molecule, whereas sandwich assay is used for bigger molecules like glycoprotein hormones, like TSH and prolactin. The gold standard is a mass spectroscopy, but mass spectrometry is used mainly for the steroid hormone paneling. We don't use mass spectrometry for a routine screening of a pituitary hormone assay. And common hormones which are done include prolactin, ACTH, cortisol, GH, IGF-1, LH, FSH, TSH. I have not included the posterior pituitary hormones in this because oxytocin we generally don't measure it in our clinical practice, that is in a day-to-day practice, and vasopressin, which comes from the posterior pituitary, there are assays for vasopressin, but they are done mainly in a very special settings, especially when we suspect diabetes insipidus and when we do a water deprivation test. There is a point, but even in water deprivation test, we don't measure vasopressin directly, because we measure the other parameters which are affected by the vasopressin. So I have excluded the posterior pituitary hormones from my talk. So coming to the, as I told you, there is a competitive assay, there is a sandwich assay. Simple thing is, in competitive assay, you put the hormone, you put the radio-labeled antigen. Both will try to bind with the antibody, with the captured antibody. So what will happen is, when the hormones, excess of hormone is there, that will be washed out. So the signals will be captured more. So the captured signal, the proportionate intensity of the captured signal is inversely proportional to the hormone levels. So higher you get the signals, the hormone level, the actual hormone level is less. That is in terms of competitive assay. But the exactly opposite is there with the sandwich assay, where the radio-labeled antibody will be there and the hormone also. They will both bind to the capture antibody, and the capture antibody, the signal antibody will reflect the signal. So the signals will be directly proportional to the hormone concentration. So in competitive, it is inversely proportional. This is mainly for people who are doing biochemistry, they have to know that. But for a clinical practice, why it is important, I will come a little later. So as Sir Moses had pointed out, you need to see the tropic hormone, target hormones. Like interpreting the assay without interpreting the target hormone will be a futile exercise. As we know that there is a thing which is maintained from the hypothalamus. It acts at the pituitary level, then it acts at the target organ level, and then the target hormone acts released from the target glands, especially from the thyroid, adrenal, from the gonads, and then they act at the cellular level to cause the desired effect. So if we understand these 4 steps, then we won't interpret the hormone, the pituitary hormones in isolation. We will interpret always with its target hormone and as well as with the cellular action what it causes. Except prolactin, all are stimulating hormones which are coming from the pituitary. Only in prolactin you have got an inhibitory hormone. That is prolactin inhibitory factor, which is not well characterized, but dopamine is a stimulator. For the dopamine is considered to be the this thing, prolactin agonist. So the interpretation, when you are given a panel of pituitary hormone tests, what are the basic things that you need to do before you interpret? One is the age of the patient and the sex of the patient. Second, if you are dealing with an adolescent or child, you should know the pubertal status of the child before we interpret. Many times we have seen that FSH of 0.1, or 2 and all will be considered as hypogonad in a 12-year-old boy or in a 13-year-old boy, where the pubertal status, they would not have even gone through the first stage of puberty, and wrongly termed as hypogonadism. Sometimes even testosterone has been given to these children and ending up with a precocious puberty for them. There's no need for doing testosterone this thing for these children. Health and well-being is very important. Many times we'll get calls from ICU saying that thyroid function is altered, T4 is low, T3 is low. Is it a hypothyroidism? Should we treat them with levothyroxine? So the stable outpatient or sick inpatient, that matters a lot. Whether the patient is pregnant, whether in the postpartum state, whether in the post-menopause state. Suppose a 50-year-old or a 60-year-old lady who has attained a menopause comes with the FSH of say 3. Definitely it is not normal. The FSH what we expect is more than 30, and if it is 3 or 2, we should consider something like a hypopituitarism in that lady. And post-thyroidectomy status again, whether the thyroidectomy was done for a carcinoma or for a benign lesion, that is important. Sometimes pituitary surgery can alter the values, as you all know, and gonadectomy. So all these status is very important, relevant before we interpret the assay. Medications, I think the single most, even if we forget everything, if we just remember one thing, always take a drug history before interpreting the thyroid hormone. That will be a single take-home message, I would say, from this talk. So you have n number of medicines which can alter all the thyroid function, from thyroxine, OCP, steroids, antipsychotics, proton pump inhibitors, GnRH analogs. So many things are there. Like so, there should be a detailed drug history at least. Even ask the patient to bring all the tablets. The patient has to show all the tablets. Somewhere there will be one tablet which will be altering the hormone levels. Many times a prescription may not contain that tablet. So I have several times asked the patient to bring all the boxes from the house and found out that there are some medications like biotin, as sir pointed out, which is interfering with the assay. Then what type of test was done, whether we have done a stimulation test or a suppression test. Many times you will get a cortisol value of less than 0.5. If the patient has already seen an endocrinologist, the patient would have got a cortisol value of 0.5, and then you will be interpreting it as a low cortisol, but it would have been an dexamethasone suppression test. So always what we have to do is we have to write in that bracket, it's a ODST or DEXA suppression. I used to write in the paper itself, in the investigation paper, so that the next doctor who is seeing that value should understand that this is not a random cortisol or a baseline cortisol. This is a cortisol which is done after the suppression test. That will sometimes remove so many hurdles in our management. Then the target hormone level, that is the most important things I would say. So coming to the pitfalls, what are the problems which we are facing while we do the interpretation is, one is a pre-analytical factor, second is analytical and the post-analytical factors. So pre-analytical, the biology, pulsatility, circadian rhythm, we all know all these things, that all the hormones are secreted in pulses. So growth hormone is secreted in pulses of every half an hour to 45 minutes. Doing a random growth hormone, one of our professors used to say it is endocrinology, not endocrinology. So it's criminal waste in doing just a growth hormone assay, growth hormone test for the patient. Don't do that. ACTH cortisol follows steep diurnal pattern and then a random cortisol sample unless the patient is really sick or having hypotension. We do random cortisol sometimes, but it is in a specific isolated setting where we can do a random sample. Otherwise, we cannot do a random cortisol sample. Second is binding problems, like if a person is pregnant, definitely total hormones will be varying. That is not regarding the pituitary hormone assay as such, but I am talking about the target hormones. Third is the physiology. We all know pregnancy elevates the prolactin to 10-fold. Even the cortisol binding globulin will increase. Cortisol will be high for those patients. And obesity will suppress the growth hormone. That is very important. So just to highlight the fact that if you take just causes of hyperprolactinemia, you can see that there are hundreds of causes of hyperprolactinemia. Only one reason is prolactinoma. And probably we will be overdiagnosing prolactinoma if we are taking a careful history. We have to rule out physiological causes. A patient would have done a night shift and given a prolactin assay. Even a sleep disturbance can affect the prolactin. Many times we see night shift workers coming at morning 8 o'clock giving a prolactin sample and all. When you ask them to sleep normally for 1 week and then do the prolactin, that will become normal for them. So exercise, coitus, stress, suckling, renal failure, hepatic failure, so many things will alter the prolactin. So before we jump to the diagnosis of prolactinoma, get a careful history from this. So many times a question will be asked, so shall we go for a dynamic testing, because the pituitary panel is not very clear cut, it's confusing. So shall we go for a dynamic testing for these patients? The commonly used dynamic tests are growth hormone stimulation tests. We all know there are several ways to do that. I am not going into the detail. We have growth hormone suppression test to rule out acromegaly, synaptin stimulation test, DEXA suppression test commonly used for endogenous Cushing's to rule out. Why I am telling you in endogenous is we have to rule out exogenous Cushing's before we diagnose an endogenous Cushing. So a baseline cortisol, a morning cortisol would be mandatory in several of our patients. GnRH stimulation we do for both the things, for hypogonadism as well as CTGP. For precocious puberty also we do a leupride test. That's a different thing. Water deprivation test, as I told you, for ruling out a diabetes insipidus or for confirming it. But even dynamic tests have problems, because what pre-test conditions you are using. The patient should have a proper sleep, proper anxious state. Anxiety can itself induce so many things. Protocol errors, you should be doing it very carefully. At 30, 60, 90 means it should be 30, 60, 90. It should not be 45, it should not be 110 kind of thing. And which peak assays you are using, what kind of cutoffs you are using, very important, especially for growth hormone. The cutoffs were 10 with the previous assays. Now the cutoffs have become 5 for the newer assays. And so many changes are there. So dynamic tests definitely will improve the clarity from the baseline test, but they are not gold standard. Again, go to the patient's history before you do the dynamic test. Just some clinical cases I will be going through while I am discussing these things. This 12-year-old boy was brought for a short stature evaluation with a height of 3rd to 10th centile, weight of 90th centile, and the projected adult height is less. So genitalia were pre-pubertal. Random growth hormone was done, which was 1 nanogram per ml. Clonidine stimulation test was also done, which was less than 5 nanogram per ml. So the patient will be diagnosed usually with a growth hormone deficiency. The MRI pituitary will be normal in these children, and the patient will be started on growth hormone injections also. Many times this happens, especially availability of growth hormone in some of the government setups have become quite common now, and there is a rampant misuse of growth hormone also. I would like to point out this fact, because many children were wrongly diagnosed as growth hormone, because you have you have a hammer, everywhere you can nail that. So that kind of a thing has happened now. So main important thing is obesity can alter the clonidine stimulation test also. Now commonly used test is clonidine stimulation test for growth hormone. Even growth hormone can be low in clonidine stimulation test if the child is obese. So instead of making a very rare diagnosis of growth hormone deficiency, go for a common diagnosis entity like constitutional delay, careful follow-up of a height velocity measurement. You take a IGF-1, do IGF-1 standard deviation score, get a clinical history properly from the family pedigree chart as whether the father had attained puberty at what age, mother attained puberty at what age. That will solve the problem instead of making a wrong diagnosis. And the second thing is, we will be giving over hope for the children and the parents, saying that growth hormone will make him tall. But after 1 year of therapy, it won't be peaking that much, and the patient will be literally confused and anxious. So if we wrongly diagnose like that. Hook effect is one thing which definitely is common in prolactin assay. When there is a lot of hormones evolving, suppose actual prolactin is more than 10,000 or 20,000 or 1 lakh, many of the prolactin will be washed away or it will be competing with the sandwich assay. So this is what I told you, like in a sandwich assay, a very high prolactin can be falsely diagnosed as a normal prolactin, and the patient will be diagnosed as a non-functioning pituitary tumor. Actually, this patient had a 2.5 centimeter of MRI tumor in the pituitary, but the prolactin value was only 120. Generally, the tumor size and the prolactin should correlate if it is a prolactinoma. But the prolactin is not correlating with the tumor size for a 2.5 centimeter. But in that situation, we should ask for a prolactin in dilution. So the lab should be able to do it in 1 in 10 or 1 in 100 dilution, where you will get the actual value of the prolactin. That will be 5,000 or 10,000 sometimes. So what is the clinical problem in this is, we will be wrongly diagnosing them as a pituitary adenoma non-functioning tumor, and we will be operating on that patient. Whereas if it is a prolactinoma, definitely dopamine agonist will be the first line of treatment for those patients. There is no need of surgery. So unnecessary surgery can be avoided if we do a prolactin in dilution in these situations. Third is a macroprolactinoma, which is again, sir pointed out in his introduction that macroprolactin is a very common variant of prolactin, which is a natural variant of prolactin, and that will interfere only with the assay. That doesn't have any clinical problem. That if some patients may have a naturally high prolactin called macroprolactin. So identifying a macroprolactin is very necessary before going for a MRI pituitary, because macroprolactin assays are also commonly being done. You do a polyethylene glycol precipitation, and if more than 60% reduction in prolactin is there after the precipitation, that confirms that the patient is having a macroprolactin. So in this kind of situation, suppose this lady comes with infertility and irregular cycles, will have a prolactin of 68 and wrongly diagnosed as prolactinoma, then dopamine agonist therapy, whereas macroprolactin can interfere with this assay. The patient may be having some other medicines like metoclopramide, antipsychotics, so many other things will be there which may be interfering with the prolactin. So not all hyperprolactinemia is equal to prolactinoma. Repeat in fasting, repeat in non-stressful situations, and you will end up getting mostly normal values, and do a macroprolactin if there is no clinical symptoms for the patient. Many times fertility may be due to some other issues and prolactin may be due to a macroprolactinoma. And again, interferences in the analytical thing, we have got heterophile antibodies, we have got biotin interference, as sir rightly pointed out. High dose of biotin is given for hair loss treatment. What happens is that patient will go to hair loss treatment, they will be given biotin, then they will do a TSH. TSH will be suppressed for this patient, and the patient will come to you saying that suppressed TSH is the cause of hair loss, whereas suppressed TSH is because of the high biotin given to the patient, because biotin is one of the important enzyme which is used in most of the lab biotin streptavidin assay, and cross reactions sometimes can happen. So a TSH 0.1 with a normal T4, T3 clinically euthyroid patient, no need to make a diagnosis of a hyperthyroidism or subclinical hyperthyroidism. Just take the tablets from the patient's shelf and examine. You will get any biotin preparation, stop the biotin for 72 hours, recheck the thyroid function. The thyroid function will become normal in those patients. So pre-analytical and analytical we have discussed. Now coming to the post-analytical. Post-analytical is very important again. Always see the reference range. don't go with whatever is done. As I told you, like DEXA suppression test, cortisol will be less than 1.8. That is normal. We should not be interpreting it as a low cortisol. So these are some of the post-analytical things, because the patient won't know that the tablet was given to suppress the cortisol. Second is, don't compare one lab value with the other, because many times lab to lab there will be assays will be different, the kits used will be different. So always go back to the lab person and ask whether they have changed the kit recently, because they would have changed the kit but they would not change the normal range. These are some of the post-analytical errors. Many times we see TSH of more than 100. It's given as TSH of more than 100 every time. Ask them to do in dilution and get the exact TSH value. Don't really believe that the TSH is, suppose the TSH was 400 initially and you treat for 2 months and the TSH will be 200 after 2 months. Both will be labeled as more than 100 only. So there is no point in getting a value of more than 100 TSH. So all these are some of the post-analytical points which we should take into account. So concluding my talk, assays are powerful but prone for errors, and always suspect the classic pitfalls like hook effect, macroprolactinemia, biotin interference and heterophil antibodies. Never interpret assays in isolation. In any kind of mismatch, pause and reassess the patient. And the most important thing is a thorough clinical history and examination is the most important. It can never compensate for a hormone assay in any given individual, and unnecessary MRIs can be definitely be avoided if we do this. Thank you.
Thank you very much.